I want to thank the organizers for the invitation to present this talk. What everyone should know when diagnosed with Parkinson's disease. I'm Dr. Tinatin Chabrashvili, Professor of Neurology and Neuroscience at SUNY Upstate Medical University. I have no relevant disclosures. Here is the outline of my talk. In the beginning, I will introduce the most common symptoms of Parkinson's disease, both motor and non-motor. I will touch on answers to a few of the most common questions that I hear in my clinic. What are the common medications used to treat Parkinson's disease? How does the disease progress? Can we cure Parkinson's disease? Does exercise help? Afterwards, I will touch the most important things that people should know when managing Parkinson's disease and how to navigate in the world of Parkinson's disease. I will wrap up with the discussion how you can help your doctor to manage your disease symptoms. Let's start with the description of Parkinson's disease. What is Parkinson's disease? This is actually a movement disorder that affects movement. However, it also has a significant non-motor manifestations. The underlying pathology is related to the loss of pigmented cells in the brain due to accumulation of significant abnormal inclusions called Lewy body. Parkinson's disease is a very complicated disorder. It has a complex etiopathogenesis, and the treatment is not always straightforward. This slide outlines the complex nature of Parkinson's disease. However, I will not go through all these complex mechanisms. So when should we be concerned that someone is experiencing symptoms of Parkinson's disease? What are the red flags? People may notice shaking, we call tremor. They may move slower than usually, become stiff or rigid. They may lose balance or have a hard time of walking. However, some additional symptoms also may include loss of ability of thinking. At times, they may lose touch with reality and experience things that are not there. We call them hallucinations. Their face may look different. They may feel depressed. They may have a lack of motivation. They may experience loss of smell. They may feel tired and fatigued all the time. The disease can also cause constipation, sweating, trouble of urinating, trouble of swallowing, sexual problems, and orthostatic hypotension. Delira is a very important symptom of Parkinson's disease, and we will talk about it a bit later. How quickly does Parkinson's disease progress? So this is a very important question, and I hear about it all the time. What is important to recognize that the disease starts way early than first Parkinson's disease motor symptoms. It may start even 10, 20 years prior. Some of the early symptoms, so-called non-motor symptoms, may include mood problems such as anxiety, depression, some gastrointestinal symptoms such as constipation. Now let's focus on motor symptoms. So initially, 4 cardinal symptoms of Parkinson's disease were described: tremor, rigidity, postural instability, and bradykinesia. However, motor symptoms may include diminished arm swing, diminished blink rate, monotone face, freezing gait, stooped or flexed posture, rigidity, which is the same as stiffness. Balance issues, doctors call postural instability, small handwriting, facial masking, shuffling gait, difficulty with turning and drooling as well. It could be difficult to get up from a soft chair. Sometimes patients note such symptoms as curled, clenched toes or painful cramped feet, and we call this symptom dystonia. Not every tremor is Parkinson's disease. Most frequently, patients with Parkinson's disease experience rest tremor. The tremor increases with mental distraction, can start in individual finger, often persistent with walking, usually affects hand and forearm, may begin in the foot, may involve the lips, chin, or tongue. Usually head or voice tremor, not typical for Parkinson's disease. And tremor can reemerge while maintaining posture next. Shuffling gait and freezing of gait is a very important and disturbing feature of Parkinson's disease. Patients have difficulty to initiate gait. They sometimes are trembling in place, shuffling forward, or sometimes can completely become frozen to the ground. We call complete akinesia. They have difficulty with turns, especially in the crowded areas or with dual tasking. Unfortunately, falls are frequent later symptoms in Parkinson's disease, and the cause could be related to Parkinson's disease itself or could be external. And Parkinson's disease-related causes include postural instability, inappropriate weight shift, freezing of gait, involuntary movements that we call dyskinesias, orthostatic hypotension, visual impairment, urinary dysfunction, and even medication timing. As I mentioned earlier, the causes can be external, such as environmental, uneven surfaces, obstacles, or even footwear. So patients have to be vigilant about these causes of falls to address the correct problem and therefore to treat appropriately. Well, as disease progresses, non-motor features become more prominent. However, number of non-motor symptoms can reemerge even before before the motor symptoms, so-called during prodromal state. We can divide non-motor features into 4 major categories: sensory, musculoskeletal, autonomic, sleep-related, and neuropsychiatric. And we have to remember that these non-motor features have a significant impact on patients' quality of life, and they can really truly impair. And also to remember that they are persistent throughout the lifetime, and unfortunately, levodopa has no impact on these symptoms. So let's expand on non-motor features of Parkinson's disease. This slide really highlights all the significant non-motor features, behaviors, which includes mood, cognition impairment, hallucination and psychosis, impulse control, fatigue, and apathy. Sleep disorders, such as REM behavioral disorder, so-called sleep enactment, excessive daytime sleepiness, however, nighttime insomnia, both falling asleep or maintaining sleep. Autonomic features are very extensive. These are gastrointestinal, genitourinary, cardiovascular, thermoregulatory, dysphagia, and drooling. And the last category is sensory musculoskeletal. That includes smell change, visual system abnormalities, pain, posture, and skin. So some of the highlights of sensory musculoskeletal non-motor symptoms are fatigue, internal tremor. Some patients, they say that I feel that my body is shaking inside, and there is a significant postural deformities, shift of balance. Patients may experience leaning towards one side or another, so-called pizza syndrome. Most frequently they are leaned forward. Dysautonomia is very common, and it affects approximately 14 to 50% of patients. Constipation is the most frequent, and often it occurs even during the prodromal stage, followed by orthostatic hypotension and urinary symptoms. Gastrointestinal symptoms include constipation, nausea, and vomiting. However, the latter could be related also with medication intake. So make sure that you bring up this symptom with the doctor, because she or he may have a way to reduce nausea and vomiting and relieve constipation. So in terms of the genitourinary dysfunction, urinary frequency happens very often. Overall, the symptoms occur up to 60% of patients. And sexual dysfunction is also very disturbing. Change in libido and erectile dysfunction in males. So let's talk about orthostatic hypotension. Patients may feel dizzy or lightheaded because drop of blood pressure when they change the position. It happens approximately 30 to 58% cases, and at the onset, approximately in 15% of patients. So what are the implications of orthostatic hypotension? They can contribute to falls, they can contribute to fatigue, anxiety, even cognitive performance. And sometimes it requires special treatment and pharmacologic or non-pharmacologic to address this issue. How about thermoregulatory dysfunction? It ranges from excessive sweating, sometimes even decrease of sweating. And we have very limited tools to address this symptom. Sometimes we can use beta blockers, which lowers blood pressure as well, so we have to be really careful about it. The skin changes have a broad spectrum. You can see oily or flaky or inflamed skin, and dry skin is very common in patients. So just briefly about the sleep abnormality. It is well known that even if a healthy person does not sleep well, next day does not feel refreshed and may even experience non-optimal thinking. Therefore, it's very important to address this symptom with either sleep hygiene or different tools that your doctor may have. REM behavior disorder is characteristic, and we often ask the patient about sleep enactments. How about neuropsychiatric symptoms? At some point, it occurs approximately in 40% of patients. And the most frequent is depression, as well as anxiety, panic attacks, apathy, hallucinations, executive dysfunction. In later stages, unfortunately, it may also manifest during dementias. Apathy is a lack of motivation, and this especially can be disturbing for the caregivers. It occurs approximately 15 to 70% cases. In terms of the cognitive impairment, well, it has a very broad manifestations, and sometimes patients with Parkinson's disease ask me, is it related to my Parkinson's disease, or am I developing Alzheimer's disease? So it has a very broad spectrum. It's sometimes present as just slow thinking. Sometimes it slightly affects the daily activity, and we call mild cognitive impairment. And at times it may progress at the later stage to dementia. It's a very heterogeneous group of symptoms, and frequently manifests as executive dysfunction, working memory impairment, attention problem, and visuospatial dysfunction. What we have to remember that the progression is different in each individual, and it's very important to gather the information from the caregiver, to remember that cognition is not just a memory, and this difficulty that patient with Parkinson's disease experiencing is not normal aging, and has functional implications. Next. How about psychosis in Parkinson's disease? It actually affects approximately up to 50% of patients at some point of their disease course. And there are some risk factors, advanced stage, advanced disease course, and some of the medications. It has a very broad presentation. However, visual hallucinations are the most frequent. We have to remember also the impulse control disorders. And sometimes they can be related actually to the medication intake, especially dopamine agonists. It occurs approximately in 2 to 10% of cases, but could have a detrimental effect on the patient, especially the financial aspect. So please always discuss your symptoms with the doctor, and ask about this medications, and make sure that these are not the side effects of the pharmacotherapy. How about fatigue? Fatigue is overwhelming sense of tiredness, and many patients are experiencing fatigue. It could be related to localized muscle fatigue, or it could have a central etiology. Okay, let's move to the next section. Is there a test for Parkinson's disease? Unfortunately, we don't have a specific one single test that can diagnose Parkinson's disease. Usually, clinicians diagnose Parkinson's disease on the basis of person's symptoms. Therefore, it is absolutely crucial to provide accurate history to your doctor. Sometimes doctors get laboratory tests that may include imaging or blood tests in order to rule out any other causes of similar symptoms. However, if the presentation is typical, we usually don't need to obtain the imaging studies. Important consideration during the diagnosis includes unilateral, one-sided onset, progressive nature, good response to the medication, and the clinical course more than 10 years. So how about the treatment of Parkinson's disease? Well, today we cannot cure Parkinson's disease, unfortunately, and we don't have effective neuroprotective therapies. However, there are many medications that we can use to improve the symptoms of Parkinson's disease. How should we start treatment? And I would say that lifestyle change and healthy habits are very important, even in the beginning. Exercise, diet, sleep, social intellectual activities, and psychological status. We will come back and discuss exercise a bit later. So this is a complex slide that outlines pathophysiologic basis of therapeutic targets for motor symptoms. There are two main categories of medications that we use to treat motor symptoms: levodopa and dopamine agonists, such as pramipexole, ropinirole, rotigotine, and apomorphine as well. We have other medications as well that we can use to treat motor symptoms, such as MAO-B inhibitors, anticholinergics, especially for management of tremor, amantadine, COMT inhibitors, and relatively newer group of medication, adenosine A2A receptor antagonists. So there are a number of misconceptions related to levodopa. And patients sometimes ask, if I take levodopa now, I will develop tolerance. Or I'm afraid to start levodopa because I will use up the good time. Or I should take medication only when I find impossible to carry out my daily activity. And the most importantly, sometimes people think that levodopa will cause faster progression of Parkinson's disease. So these are most common misperceptions. We have a number of preparation of carbidopa levodopa. We have immediate release, known as Cinemet, and there are, this is a brand name, and there are generic formulations, oral dissolving formulation named as Parcopa, control released formulation, and latest Rytary, levodopa intestinal gel Duopa. In 2018, inhalation formulation of levodopa Invrega was introduced. There are a number of newer formulations in pipeline, and one of them is the continuous subcutaneous infusion and accordion pill as well. So just this slide highlights dopamine agonists that we use for quite a long time. And there is a continuous debate which one should we use in the beginning, levodopa or dopamine agonists. And there are pros and cons for both options. Both group of medication have side effects. Levodopa has more side effects such as nausea, dyskinesia, so-called involuntary movement, motor fluctuations, and dopamine dysregulation such as addiction than dopamine agonists. However, dopamine agonists have greater incidence than levodopa, and this side effect of the following side effects: impulse control, excessive daytime sleeping, hallucinations, orthostatic hypotension, and pedal edema. And as you remember, orthostatic hypotension and hallucination actually are the symptoms also natural course of disease. So we have to be cognizant when we are starting these medications. Just quickly to touch base about apomorphine pen, it can be used as a rescue drug, and sublingual formulation also is available. You may already heard about the medication amantadine. It has a modest effect. This is an NMDA receptor inhibitor. We have to use it carefully because it also has side effects such as hallucinations and anticholinergic effects. There is a newer formulation such as extended release formulation of amantadine. And this slide just lists number of other compounds that can be used for motor fluctuations and dyskinesias. So what guides the initiation of symptomatic treatment? Age is a factor, whether it's less than 70 or greater than 70, level of disability, comorbidities, employment status, and insurance, and cost of medications. Employment status is important because most of the times patients take this medication more than 1 time a day. So sometimes it can become intrusive during the busy daily activity. Just to mention that besides the pharmacotherapy, there is a procedure, deep brain stimulation, that could be successfully used in the subset of patients and could be very effective as well. So let's move to the next non-pharmacologic options of treatment. As I said earlier, lifestyle changes and healthy habits are very important. Diet, specifically Mediterranean diet, has been associated with improved brain health, and even whether we are talking about Alzheimer's disease or Parkinson's disease, or even healthy aging. So it is important to carry on the healthy lifestyle, to make the healthy dietary modification, and exercise. So the question, does exercise help? And I would say yes. And we have to engage both physical, occupational, and the speech therapy as well. There are 3 layers. Obviously, the physical activity that everybody has to do, and the more structured exercise that is done in conjunction with physical therapy and occupational therapy. It is important to highlight that people with Parkinson's disease have move less than normal people, and it is important to have some mobile recorders, because they can register how many steps people make. And overall studies show that people with Parkinson's disease, they move 30% less than healthy control. So these are a number of different type of exercise that has been beneficial for patients with Parkinson's disease. It includes just simple walking, Tai Chi, progressive resistance, forced bicycle riding, shadow boxing, dance therapy. And the benefits are just beyond of simple feeling good. It improves the brain health, and there is evidence it decreases motor severity scores, increases functioning, improves balance, reduces falls, improves cognition, mood, and overall, actually, quality of life. There is extensive research going on to come up with new therapeutics. And that includes ongoing clinical trial, investigational, gene therapy. Hopefully we will hear about this trial soon. And it's a very hot topic, alpha-synuclein immunotherapies. It has some limitations. We think that it may be too late to start alpha-synuclein immunotherapy when patient already has motor symptoms. However, Pros are that it targets the pathologic aggregates and it passes a phase 1 safety and tolerability trial. So what information people should have to best navigate living with Parkinson's disease? First of all, we should remember that at early stages, patients with Parkinson's disease have only mild symptoms. And as it progresses, it can affect daily life more significantly, especially ability to work and to perform everyday activities. And at the later stage, patients may require more help from their caregivers. What are the questions that you need to ask your doctor to help you to understand risks and benefits of medications? Some of the questions include, doctor, what medications would you suggest I take? What are the side effects? How much are my symptoms likely to improve with each medication? And what happens if I don't take the medication? And of course, patients always ask, is there any cure? But as I already mentioned, unfortunately, we don't have cure for disease at this time. Here are some tips on taking oral medications. Take the medication as your doctor suggested. I advise not to skip the pills, and don't take the extra pill unless your doctor recommends. Have a pill box, and this applies not only Parkinson's disease, but it applies to any other medications. Learn about how your medications look. When you get your refill, it could be a different generic form, but that's okay, as long as you take the accurate dose of medications, and make sure you bring up any side effects that you are experiencing. So, is there anything that patient can do to make him feel better? And as I mentioned, the lifestyle modification, exercise are very important. It is important also to join social support group. And remember, you are not alone. There is an extensive support group out there. Many associations, they have a lot of information, and they are there to share your experience. Make sure that your home is safe. Make sure that it's not cluttered, and that eliminates some of the challenges and risks to fall. If you still drive, make sure that you are safe to drive, and make sure that you are tested to ensure your safety and everyone else on the road. Learn about Parkinson's disease. I always say it's the partnership between a doctor, patient, and the caregiver that allows us to treat and individualize management for each patient. Make sure that you have a list of medications that you take, plus any medications you are allergic to, or make sure that you write down all the previous medication that you used for Parkinson's disease in the past. In the ideal situation, bring the bag with pills, because in that case, there will be no, it will be clear what dose you take, what medications you take, and you and doctor could be on the same page more easily. And make sure that you tell your doctor if you take any over-the-counter medications, especially those for cough, cold, allergy, pain, or sleep. And this also applies other supplements. Well, in summary, as you could see, multiple systems are involved in Parkinson's disease. And this is not just a movement disorders. It has a lot of non-motor features, requires a comprehensive and interdisciplinary approach for evaluation and management. There are many medications to treat Parkinson's disease. There are non-pharmacologic tools available to improve function. Work with your doctor to individualize your care and take an advantage of telemedicine. It's possible to do a very good and comprehensive visit through telemedicine, especially at the advanced stage of disease. And remember, there is an extensive research going on for the new pharmacotherapies, and I do believe that science will come up with the solutions. There are many websites. I just highlighted one of them below. And thank you so much for your attention.